Welcome, everyone. Thank you so much for joining us for today's webinar, Preventing and Treating Muscle Loss with Age, Nutrition and Exercise for Health and Independence. We had more than 1,200 people register for this webinar, and we are so excited about the enthusiasm and interest you all have in this content. I am confident you are all going to learn a lot from these experts today. So I'm Lindsay Clark, the Senior VP of Health Education and Advocacy at the Alliance for Aging Research. I lead our efforts to educate consumers, patients, caregivers, and healthcare professionals about a wide variety of diseases, conditions, and issues of aging. The Alliance for Aging Research is a nonprofit organization located in Washington, D.C. We are dedicated to changing the narrative to achieve healthy aging and equitable access to care. We do this by advancing policies, advocating for patients, and educating through high-impact educational materials to improve the health and well-being of older adults and their family caregivers. One of those educational campaigns that we lead is Aging in Motion, or AIM. AIM is dedicated to raising awareness about sarcopenia. Sarcopenia is a serious condition that becomes more common with age. It causes loss of muscle mass and strength, and has a serious impact on the health and independence of those that are affected. Sarcopenia can make you weaker, impact your balance and ability to walk, weaken your bones, and lead to fractures, increase fatigue, raise the risk of diseases, worsen existing conditions that you already have, cause weight gain, and raise your risk of malnutrition. So before we get started and I introduce you to our great experts, I want to thank our sponsor, Nestle Health Science, for the support that helped make today's important discussion happen. I also have a few housekeeping points to share. First is that these presentations are pre-recorded so that we could make sure we didn't have any trouble with technology, or at least lower the risk. But we will be back for a live Q&A at the end of the presentation. So please, as you think of your questions, submit them through the Q&A icon at the bottom of your screen. Second is that we do have closed captioning available, so you should see a notification about this at the bottom of your screens. You can turn it on and off by clicking on the CC in your Zoom controls. Last thing is that we are recording this and we'll share it around, so if you want to share it with others, please do so. I'm now going to introduce our first speaker, Dr. Jack Guralnik. Dr. Guralnik is a professor of epidemiology and public health at the University of Maryland School of Medicine. Dr. Guralnik received his MD from Jefferson Medical College in Philly and his MPH and PhD from University of California, Berkeley. He spent 25 years at the National Institute on Aging at the National Institutes of Health. He's board certified in public health and general preventive medicine, and he's received many awards for his work. His primary interests focus on physical function and disability, the benefits of physical activity, and factors associated with healthy aging. He is a world-renowned expert on sarcopenia and muscle health and aging, and has served as an advisor to AIM for many years. We are so grateful for Jack's guidance and dedication to this issue.
It's a pleasure being with you here today to talk about sarcopenia. Sarcopenia has been defined as a progressive and generalized skeletal muscle disorder that involves the accelerated loss of muscle mass and function. The word comes from the Greek word sarx, which means flesh, and penia, which means poverty. There have been a number of milestones in the history of sarcopenia. It's a fairly recent term, introduced in 1989 and then worked on in the 1990s. There have been several milestones along the way. Initially, sarcopenia was defined simply using results from dual X-ray absorptiometry, or DEXA. This was found not to be the complete answer and was lacking in some ways, which I'll talk about. And in 2010, a number of consensus groups decided that muscle function, either muscle strength and or physical performance, needed to be introduced into the concept of sarcopenia. Recognition of sarcopenia as an independent condition within ICD, or International Classification of Disease Code, occurred in 2016. And then in 2020, there was an International Sarcopenia Definition and Outcome Consortium, which voted to exclude lean body mass, which is measured from DEXA, from the sarcopenia definition because of some unsatisfactory results that were found using it, which I'll show some of. When we follow populations over time or look at different age populations, we see that the loss of muscle and strength accelerates with time. This figure shows the decline in knee strength and muscle mass starting at age 25 and going through 85 and older. The open bars show the loss of muscle mass, and you can see that increases over time, but the decline in muscle strength in the dark bars occurs at an even greater rate, so that by the time people are 85 and older, in that decade, they're losing 35% of their strength. This shows a similar type of finding following populations over time. The top line shows area or muscle quantity and shows that by age 85, people only have 75% of their muscle mass, or they've had a 25% loss. The decline in strength is even steeper, so that less than 50% of strength compared to age 20 is found in those who are 85 and older. This indicates that strength is lost at an even faster rate than muscle itself. And this is because strength involves both the amount of muscle you have, but also muscle quality and also things like the innervation of the muscle, which declines with age. So how do we know who has sarcopenia? We can learn a lot by just talking to our patients and asking certain questions related to strength and functioning. This is a list of questions from a screening questionnaire called the SARC-F, and it shows a good example of things that are affected by sarcopenia. So strength, such as asking how much difficulty you have lifting and carrying 10 pounds, assistance in walking, rising from a chair, climbing stairs, and falls. And so this is useful in doing an initial screen for sarcopenia. But if we're really going to define sarcopenia well, we need some more objective measures. And this shows three domains, kind of like the three legs of a stool, that have been used generally by groups around the world to attempt to define in clear terms what sarcopenia is. So the first is muscle quantity. And as I said, this was initially assessed with DEXA, but problems were found with DEXA. There's a new method called D3 creatine, which uses a non-radioactive isotope of deuterium to label the creatine, which then is a fixed quantity, is actually drunk, and then the patient is assessed 3 days later with a urine sample to see how that creatine, which only goes into the muscle, how it's diluted by the body's creatine and creatinine, which it's converted to. Strength can be measured with grip strength. A chair rise test is a good measure of strength. And then function, things like gait speed, the up and go test, and the short physical performance battery, which assesses several components of lower body functioning. So this demonstrates the issue of how the DEXA is not terribly good in terms of being correlated with other measures of function. So if you look at the graph on the upper left, the open bars show the quartiles of body mass as indicated by this new method, the D3 creatine. And it shows a very clear stepwise increase in the walking speed as the muscle mass, as measured in this way, increases. The filled in bars on the right relate to appendicular lean mass, which is assessed with the DEXA, and it shows a very poor relationship. We also see the same thing in the graphs in the upper right, looking at lower extremity power, where there's a very nice stepwise relationship with muscle mass as measured with the D3 creatine, and virtually no relationship with the appendicular lean mass as assessed with DEXA. This also shows how, of these three components proposed for defining sarcopenia, how low muscle mass does not relate to an important aspect of sarcopenia, which is falls. We see that the low muscle mass group on the left, and this is comes from definitions from two different working groups on sarcopenia, both showing the same results, that those with low muscle mass compared to the people in the cohorts without low muscle mass are not at increased risk of falls, whereas both low grip strength and slow gait speed do have a relationship, an increased risk of falls compared to people that have normal grip strength and normal gait speed. So what is the prevalence of sarcopenia? Of course, with these issues related to problems with defining it, we're not going to have exact numbers. One estimate is that 11% of men and 9% of women who are community dwelling and 65, this is actually for 60 and older, have sarcopenia. This is a rough estimate. It's probably somewhere between 10 and 20% by a number of different surveys. 23% of men and 24% of women who were hospitalized have been found to have sarcopenia, and 51% of men and 31% of women who are in nursing homes have sarcopenia. So we find that in terms of the whole population, people with older age, women, lower education, individuals, people of lower socioeconomic status, being underweight and lower birth weight are all associated with a higher likelihood of sarcopenia. People have looked at a number of potential causes of sarcopenia, trying to understand where it's coming from. There are age-related changes, which are probably play an important role. Lower hormone levels, changes in the cells, decline in ability to convert protein to muscle. Number of lifestyle factors, which we'll be talking about today: inactivity, prolonged bed rest, loss of mobility, low protein and calorie intake, and dental and oral problems have all been shown to be related to sarcopenia. And then a number of diseases, you see a list of them on the right side here. This is just a partial list of chronic diseases that have been shown to be related to sarcopenia. This is a really interesting study on the effect of bed rest on muscle, published in JAMA in 2007. This study took healthy older people and basically put them to bed for 10 days. And what they found is that over that time, they lost 2 pounds of muscle in the legs. If you can picture 2 1-pound steaks, one being lost in each leg, this is a tremendous amount of weight. They also found that along with that muscle loss, there was more than 15% loss of strength in the lower extremities. So you can imagine with these effects of sarcopenia that there will be important consequences. And these have been documented in a number of studies. On average, individuals with sarcopenia have a 58% higher risk of fracture than people without the condition. The risk of disability has been found to be 1.5 to 4.5 times higher in older adults with sarcopenia than those without the condition. And then people with sarcopenia have a 13.8% increased risk of dependency in their activities of daily living compared to those of similar age without the condition. Sarcopenia has also been shown to be related to mortality. This study put together a number of different studies that looked at sarcopenia and mortality and found that even after adjusting for the chronic conditions that people with sarcopenia have, there was a 2-fold increased risk of mortality in those with sarcopenia. Estimating the cost of sarcopenia is quite a challenge, as people with sarcopenia often have many other coexisting conditions. But it was estimated that the cost of hospitalizations in individuals with sarcopenia was over $40 billion. And because individuals with sarcopenia are nearly twice as likely to be hospitalized as those without sarcopenia, on average, those with sarcopenia pay over $2,000 more annually on hospital stays than those with normal muscle mass and function. It's clear that sarcopenia is an important issue in the older population. The medical establishment has been somewhat slow in coming to terms with taking sarcopenia on as an important aspect of aging to be dealt with medically. The Aging in Motion Coalition funded a research project that assessed the familiarity with sarcopenia in 4 medical specialties. That was internal medicine, family medicine, geriatric medicine, and physical medicine and rehabilitation. And what it showed is, as expected, that the geriatricians were quite familiar with sarcopenia. 70% of them said they were very familiar with sarcopenia. But it was disappointing that less than 20% of specialists in internal medicine and family medicine said they were very familiar with sarcopenia. And then the physical medicine and rehabilitation specialists were somewhere in the middle there. There were some reassuring things that came out of that study. One of them was that physicians who were aware of sarcopenia were likely to assess for it when people had specific life events. And this shows that physicians said they would assess for muscle loss and loss of muscle strength in 82% of those who had a recent hospitalization or extended bed rest, in 75% who experienced an acute injury or fall, 56% of those who transitioned to or from long-term care, people who had recent surgery. And they were also aware that there are important social and psychological factors that can be related to loss of muscle and function, such as loss of a spouse or significant other. It was also interesting in this survey that these physicians were making clear and important choices in what they would recommend to patients who had significant loss of muscle mass and strength. And most of these physicians would do a physical therapy referral. 58% would recommend independent or at-home exercise, protein supplements, also dietary changes, and others. And these are the interventions that we're going to be talking about in the rest of the symposium. So this is a good place to transition to our next speakers.
Thank you, Dr. Guralnik, for your great presentation. I'd now like to introduce our next speaker. Dr. Roger Fielding serves as leader and senior scientist of the Nutrition, Exercise, Physiology, and Sarcopenia team. He is a professor of nutrition at the Friedman School of Nutrition Science and Policy and professor of medicine at Tufts University School of Medicine. He's also the associate director of the Boston Claude Pepper Older Americans Independent Center. Dr. Fielding is an internationally respected researcher who studies age-associated changes in muscle mass, the importance of muscle for function, and the potential for exercise, nutrition, and other interventions in preventing decline. Dr. Fielding is also a longtime advisor of Aging in Motion.
Since we've already heard about what sarcopenia is from Dr. Guralnik, I just want to talk a little bit about how I think that skeletal muscle dysfunction is really the underlying substrate of sarcopenia. And I don't think we think about muscle very often. Just remember that this is a tissue that makes up almost half of our total body mass. It plays a fundamental role in locomotion, oxygen consumption, energy metabolism, and substrate turnover and storage. It is a very dynamic tissue and can increase its energy utilization up to about 10-fold. And it has a unique ability to generate force, which occurs across a wide range of force and power outputs during daily activity. Remember, as Dr. Guralnik mentioned, the components of sarcopenia: low muscle mass, low muscle strength or weakness, and poor physical performance. And really, we think these are important because they're key barriers to independence as we get older. Well, one question you might have is, how do you know if you have sarcopenia? Now, remember, your primary care physician or healthcare professional may not really be aware of sarcopenia or may not know very much about sarcopenia. So a couple of things you can think about and even have a discussion with your provider about are, have you lost excessive muscle? Now, this sometimes would be difficult to assess presently, but don't rely on your body weight. Just because you don't lose weight doesn't mean you haven't lost muscle, and I'll show you an example of that. Do you have muscle weakness? Can you measure your muscle grip strength or know if you're developing some weakness? You should consider sarcopenia in patients or people who are non-ambulatory or cannot rise from a chair unassisted. And another useful assessment could be to assess a person's walking speed or other measure of physical functioning. And I'll show you some examples of this. Have you lost excessive muscle? Well, it's difficult in many settings to really accurately assess muscle mass or muscle size. But one thing I can tell you is don't rely on changes in your body weight. And I just want to show you an example of this. These are some CT scans of some older adults that have participated in our research studies. This is a cross-sectional look at the mid-thigh, the lower leg. This is a 70-year-old female with a body mass index of about 23. So that means she has an absolutely normal weight. If you look at the slide here in cross-section, the red band here is the fat that's under your skin or subcutaneous fat. The blue here is muscle, so that's all the muscle of your upper thigh, your quadriceps muscles, and your hamstring muscles. Just for orientation, this white area is the large bone of the upper leg, the femur. Now contrast that to an 85-year-old female with virtually the same body size, BMI of about 24. You can see that the total area of the lower leg, the thigh here, is about the same size as we see in the 70-year-old female, but very dramatic differences in the area that's occupied by muscle in blue and green here. So you see much less muscle tissue here, and a lot more of the area is occupied by fat between the muscle groups and under the skin. So while it's hard to measure muscle mass easily presently, we don't want to really look at differences in size or body weight to tell whether we've lost muscle. One thing that might be helpful is to know whether we're getting weaker or not. Do you have muscle weakness? You can measure grip strength, and it's important to note that muscle weakness occurs before the loss of muscle mass. And this is a slide you may have seen in the previous presentation, but it's just really looking at the longitudinal or the changes in muscle mass and muscle cross-sectional area or muscle strength over time. So you can see that there's about a 0.5% decline in muscle size or muscle area over the lifespan here, whereas the changes in muscle strength are more dramatic and more rapid at about 1% per year. So measuring muscle strength may be an early clue to whether you're developing sarcopenia or not. One way to measure muscle strength is to measure your hand grip strength. This can quantify the maximum grip strength in both hands. And this is an illustration of our very standard, easy to use hand grip dynamometer. This is something that you hold in your hand, and we ask you to squeeze as hard as possible until reaching a plateau in the force that you're generating. And you should be concerned if your grip strength is less than 35.5 kilograms if you're a man or a male, and less than 20 kilograms if you're a female. And grip strength is really just measuring the strength in the hand muscles, but we have very good evidence that is a good measure of whole body muscle strength. This is just showing the relationship or the correlation between hand grip strength and the muscle strength in the muscles of the lower leg. And you can see that they are very closely related here in this statistical or mathematical correlation. It's also interesting to note that multiple large epidemiological studies have shown a very strong relationship between grip strength, hand grip strength, and a measure called mortality or risk of death. And the reason that this is important is that mortality is probably the most important clinically relevant outcome that we have. So this just indicates that by measuring grip strength, it's really giving us a good measure of the overall health of a person. We can also consider sarcopenia in patients who are non-ambulatory or who cannot rise from a chair unassisted. That's something that can be very easily assessed during a normal visit with your primary care physician or other healthcare provider. Another approach to assessing physical functioning in older adults is to measure their walking speed. There are two very standard ways to do this, either by measuring the walking speed or gait speed over a very short 4-meter course. This is done very easily by having the participant or patient stand on a line, give them instructions to walk at their normal pace across a 4-meter course from here essentially to here, and essentially time them during that 4-meter walking test, calculate their walking speed. And we think, and we are concerned in people, if they have a walking speed based on this test of less than 0.6 meters per second. If your walking speed is less than 0.6 meters per second, might consider you might have sarcopenia. Another more sophisticated test, more longer test to perform would be the 6-minute walk test. This is usually done over here. You can see the example of this across a 20-meter course where we have this patient or the participant walk as fast as they can and try to cover as much ground as they can in 6 minutes. We measure the distance that they walk in 6 minutes, and we would be concerned about sarcopenia in individuals that walk less than 300 meters in this 6-minute walk test. There's also a very valid and widely used composite measure of physical functioning that was developed by Dr. Guralnik called the Short Physical Performance Battery, or the SPPB. We think of this as a key measure of health span. It is a composite measure of physical functioning, which includes a timed 4-meter walk, like I just showed you. We also measure the time it takes for a person to get up out of a chair 5 times. And then we perform a very simple balance score. Those 3 measures are used to calculate a 0 to 12 point composite score, 12 being better, 0 being worse. And this has been shown to predict disability, 12-month rates of hospitalization, declines in health, declines in physical functioning, and again, mortality. And just to show you an example of that, this is the results of the SPPB summary score here from 0 to 12 related to 1-year rates of nursing home admission. And you can see that the rates of nursing home admission begin to go up when people have SPPB scores of 7 or less. And you can see the lower on this summary score you are, the more likely you are to enter a nursing home in the subsequent year. So we would be concerned about sarcopenia in individuals that have an SPPB score that's approximately 7 or less. So now that we've thought about how to assess sarcopenia, what are the potential treatments or interventions that we could think about? And I'd like to sort of put these into maybe 3 categories here. There are a number of lifestyle interventions that we can consider: physical activity and exercise, which I'm going to talk to you a little bit more about in a second. Some nutritional interventions, which Dr. Roberts will discuss in her presentation. While there are no pharmacologic or therapies, drug therapies available for sarcopenia now, there is a lot of interest in the pharmaceutical industry and in the biotech industry in developing pharmacological treatments for sarcopenia. And these will be likely to target skeletal muscle growth, some components of neuromuscular function in muscle. They may also be targeting energy transduction in muscle. And there are also there is also some work ongoing that are looking at medicines that are currently approved for other indications that may have an indication in this condition of sarcopenia. And I also think ultimately we may be thinking about multimodal interventions depending on the type of sarcopenia, the severity of sarcopenia, where people might be prescribed medications, some type of nutritional intervention or nutritional therapy with or without physical activity or exercise interventions. But what can we do about sarcopenia now, whether we have sarcopenia or we want to prevent sarcopenia? And I think it's really important to look at the public health recommendations about exercise and physical activity that are really available to us right now, but from the Departments of Health and Human Services in the United States. These are the current physical activity guidelines for older adults. And I think if there's anything that you can do to prevent or treat sarcopenia, I think these guidelines are really important. Any exercise is better than no exercise, so move more and sit less. This is a recommendation that we could all use. We want to recommend that people exercise somewhere between 150 to 300 minutes per week of moderate intensity aerobic physical activity, or 75 to 150 minutes per week of vigorous intensity aerobic activity. Included in this recommendation is that we should perform muscle strengthening exercise of moderate to high intensity for all major muscle groups 2 or more days per week. So this is where resistance training comes in. Older adults should determine their level of effort for physical activity relative to their own level of fitness. If you're older and you have a chronic condition, you should understand whether and how this condition might affect your ability to perform regular exercise safely. However, most older adults should be able to be more physically active. When older adults cannot do 150 minutes of moderate intensity aerobic activity a week because of a chronic condition, they should be as physically active as their abilities and conditions allow. And we should also recommend some balance training in this physical activity program. Now, what about strength and resistance training exercise? What is strength and resistance training? Because I think this is a key exercise intervention for sarcopenia treatment and prevention. Skeletal muscle responds and adapts to its loading conditions. So high force power outputs induce muscle growth or hypertrophy. Low force, inactivity, bed rest, zero gravity all induce atrophy or loss of muscle. If you want to do strength training, we recommend that you do it 2 to 3 sessions per week. Engage large major muscle groups of the upper and lower extremity. We usually recommend people perform 3 sets of 8 to 12 repetitions for each of these muscle groups. When we think about the intensity of exercise, to maximize strength gains and muscle hypertrophy, training should be performed somewhere between 70 to 90% of the 1 repetition maximum muscle strength. How do I know if I'm training at 70 or 9 to 90% of the 1 repetition maximum? This is probably approximately the amount of weight that you can perform about 8 to 10 repetitions of a particular muscle exercise. And by the 8th to 10th repetition, you're experiencing fatigue. So without having to measure your strength, if you can do 8 to 10 repetitions, you're probably at 70 to 90%. If it's getting to a point where you're able to do 12, 13, 14 repetitions, then the weight's probably too low and you can probably increase the weight for those exercises. And there are many ways that you can perform strength or resistance training. You can use exercise bands, you can use weight machines, you can use handheld weights. Many calisthenics are suitable for resistance training and will allow you to perform the loading contractions that you need to get the benefits. Also, other types of physical activity, digging, lifting, carrying are all examples of strengthening exercises, even gardening to some extent. And some yoga and Tai Chi exercises also can be considered strengthening or resistance training exercises. So what's the evidence for strength training? What happens when you do resistance training? These are some studies that have been done here at Tufts. This is a study on 1 year of resistance training in healthy postmenopausal women. These women were randomized either to a health education control group or twice a week resistance exercise training of all the major muscle groups. And you can see that the group that got resistance training exercises had robust and significant increases in their strength over this 1 year period. And when we looked at the changes in lean or muscle mass, you can see that the group that got the health education control group lost lean mass, but there were significant improvements in lean mass in the group that got the twice weekly resistance exercise training program. This is also true in residents of nursing homes. This was a randomized trial of resistance training exercise in nursing home residents. Subjects either got regular resistance exercise training or nutrition resistance exercise training plus a nutritional supplement, the supplement alone, or a health education control group. And you can see that over the course of the intervention period, the group that got either resistance training alone or resistance training with the nutritional supplement had significant changes in their muscle strength and improvements in their ability to walk and perform other functional tasks. So it's never too late to start your program of exercise training. This was also a recent study that we did on resistance training in older men and women with poor mobility, showing that resistance exercise training, in this case over 12 weeks, compared to a flexibility control group, resulted in significant increases in muscle strength, explosive muscle power or explosive power, and also the delay in loss in muscle force production or muscle fatigue. So in this study in older men and women with poor mobility, 12 weeks of resistance training exercise improved muscle strength, explosive muscle power, and delayed the onset of muscle fatigue. Does exercise have important implications for preventing mobility loss? Yes, it does. This was a study we participated in called the Lifestyle Interventions for Elders, an Independence for Elders study. This enrolled 1,600 older adults that had some mobility problems. They were followed on average for almost 3 years. Individuals in this study were randomized into either a multimodal exercise program, both aerobic and progressive resistance training exercise, versus a health education control group. In this study, these are participants in the study doing their strength training and their walking. See, they're all very happy and they enjoyed the exercise intervention. In this study, the primary outcome was the onset of major mobility disability. And let me just explain that to you very quickly. At baseline, all of the subjects in our study could complete a 400-meter walk test. So this was a 20-meter course in the laboratory, and at baseline, all the subjects could successfully complete the 400-meter walk. We assessed their ability to walk 400 meters every 6 months during the trial. And what we found was that those individuals who were randomized to the multimodal physical activity intervention, this was aerobic plus resistance training exercise, had fewer participants developed the inability to walk 400 meters compared to individuals that were randomized to the health education control group. So that by the end of the study, there was an 18% reduction in the onset of major mobility disability in individuals that were randomized to our physical activity intervention compared to those that got the health education control group. So 18% reduction. This again was measured by the inability, the development of the inability to walk 400 meters. Every 6 months, we assessed this during the trial. So I'd just like to conclude with a statement that exercise and physical activity and diet remain the only treatments that we have available to us for sarcopenia. Thank you very much for your attention.
Thank you, Dr. Fielding, for those remarks. Our final speaker today is Dr. Susan Roberts. Dr. Roberts is the Senior Associate Dean of Foundational Research at Geisel School of Medicine. Dr. Roberts is an internationally known nutrition and behavioral change scientist with more than 30 years of experience developing innovative research programs to advance health in the U.S. and abroad. Dr. Roberts is going to share what it looks like to prevent and treat muscle loss and sarcopenia through nutrition, and I know I'll be taking notes.
Hello, everybody. My name is Susan Roberts. I'm from Dartmouth College in New Hampshire, and I'm very pleased to be here to talk about the changing nutritional needs of older adults and the prevention of sarcopenia. So the agenda for my talk is to talk a little bit about our older adults eating a healthy diet, the consequences of unhealthy eating and also unhealthy weight, and some summary and recommendations for how you can use this information to help yourself. Now, this is a complicated slide, but it's from our National Nutrition Survey, which tells us about the state of nutrition in the whole population in America today. And the data that we have divides people into young adults, middle-aged adults, and older adults approximately. And the y-axis shows the percentage of people who are not consuming recommended amounts, the average recommendation. And what you can see really is that there's a huge number of nutrients in which, I'm sorry, I went too through, a huge number of nutrients where most people are not consuming what they should be eating. So choline, vitamin D, vitamin E, calcium K, vitamin C, vitamin A, more than half of the population are not consuming enough of those nutrients for health. And the stars on this show the nutrients where older adults are eating even less relative to recommendations than young people. So our older adults are doing pretty poorly for healthy nutrition when it comes to the essential nutrients that we are recommended to eat based on all of the science that's happened in the last 50 years. This is another complicated slide, but it's saying the same thing in portion sizes. As you will know, the dietary guidelines for Americans converts milligrams of iron and calcium into portion sizes of different food groups that if Americans eat those, they will be getting all of the essential nutrients that they need and also all of the extra good things in food. And so we have above, below, and meeting the recommendation portion sizes. And this is for portions of whole grains, dairy, seafood, oils, nuts and seeds, proteins, and so forth. The orange ones are for things that are not healthy. So especially young adults are eating way too much of these nutrients here. So we're talking about foods with added sugar and fats, and also protein. When it comes to older adults, they are also eating a great deal of added sugar and added fat, junk food generally. Approximately half of our older adults are eating too much protein, and the other half are not eating enough. So even when it comes to these recommended food groups, we as a country are doing pretty badly, and especially older adults. It's a really reasonable question to say, well, does it matter? Some time ago, my colleagues and I, when I was working at Tufts before I moved to Dartmouth, did a summary of all of the research literature to say, how much does it matter? And although I've been working as an aging scientist for years, I was shocked that if you look at the scientific evidence for a general healthy diet and also maintaining your weight in a healthy range, can it prevent many of the things associated with old age? The answer is a resounding yes. That we prevent frailty, we prevent osteoporosis, we prevent cognitive decline, we prevent loss of eyesight and hearing, we prevent diabetes, cardiovascular disease, cancers, we prevent sleep problems, GI problems, so many things. Pretty much you prevent the same things as well by keeping your BMI in a healthy range. There are some disease-specific nutrition treatments that can be employed if you get one of these problems. But you can see from the check marks that there's many fewer things that you can treat than you can prevent. So I think the name of the game is prevention. And then we do what we can with treatment if you actually get one of those things. But nutrition is a powerful tool for keeping us healthy as we get older. The topic of this conference is sarcopenia. So what about protein? There's a lot of controversy among scientists about whether older adults actually need more protein. Some scientists are suggesting that you need about 50% more protein per kilogram body weight than younger adults to preserve muscle. The scientific evidence for this has been really poor to date, to the extent that the national dietary recommendations in America have not yet changed. That may change, but right now, protein requirements, the literature is really equivocal, I would say. But having said that, according to national survey data, approximately half of adults over 70 don't get enough protein to meet their requirements. On the other hand, I don't think we should be going crazy with protein, because older adults who consume a lot of protein are at increased risk of diabetes and cancer, which is two things that none of us want to get if we can avoid. So as a scientist, I would like to give solid information on this. And I can't do that yet because I think we need to be responsible and balance the risks and the potential benefits when the science is still emerging. I'd like to flip a bit and talk about energy requirements, because that's a huge issue that relates to healthy diet and sarcopenia in old age. All this graph shows is that energy requirements decrease as we get older. They decrease progressively. The blue lines are for men, the red lines are for women, and you can see that both men and women have decreasing energy requirements as they get older. There's a big range, which tells us, it's based on height and activity and other things, but fundamentally everybody had lower energy requirements when they are 70 or 80 compared with when they were 20. And I think we all know this on a personal level, that if you want to not gain weight, you do have to eat less. And partly it's because you're less active, but also, unfortunately, our brain shrinks a bit. The brain is a very metabolically active organ, so we have decreased energy requirements just for the organs that we have in the body. It's not just about activity. And this is important for older adults because the adequacy of meeting our nutritional requirements gets increasingly challenging as your calorie requirements decrease. If you eat at least 1,600 calories, a variety of different healthy diet plans will allow you to get everything you need. You can eat like the dietary guidelines recommend. You can eat a Mediterranean diet. You can eat a vegetarian diet or a pescatarian diet. And you can check all the boxes that you've had enough fruit, vegetables, protein, dairy, whole grains. It's fine. By the time you get down to 1,000 calories down here, there's just so little food generally that it becomes increasingly hard to meet dietary recommendations. My personal recommendation for that reason is that all older adults should ideally think about a multivitamin supplement in order to make up things that might be in short supply. But there's also eating junk food. And I think many of us think that we eat a healthy diet generally. But I know as a nutrition scientist, so many people that they say, oh, yes, I eat a healthy diet. And then I say, well, what did you eat yesterday? And a good 50% of them said, oh, yesterday was a bad day. And they go on to list a really unhealthy diet that was just yesterday. So I think many of us like to think that we eat a healthy diet, but in practice, we're not as good at it as we think. And here's the problem with that, which is that if you eat a lot of nutrient-weak foods, you can call them junk foods, unhealthy foods, they displace calories for healthier foods that you could eat. And we know that there are several factors that drive food consumption in general and healthy food in particular. So I want to go over those a bit to help you understand, that these are levers that we can really use to help ourselves as we think about focusing on reducing unhealthy foods as we get older to make space for more healthy foods when calorie requirements are going down. So what drives overeating? One is hunger. We want to eat. We want to eat when we're hungry. It's as simple as that. The American diet today contains really different nutrients and foods from what we were estimated to eat during Paleolithic times when our genome was developing. And in particular, fiber, we only eat about 1/7 of the amount of fiber that people in Paleolithic times were estimated to eat. Fiber is an enormously powerful satiety agent. It makes you feel full. So if you struggle with feelings of hunger, eating more fiber is a great way to go to fix that. It's worth noting that liquid calories do not seem to register at all for satiety. If you have a sugary drink mid-morning, you eat just as much lunch as if the sugary drink never happened. If you have an apple mid-morning, your lunch intake is lower because you're less hungry. So thinking about ways to reduce liquid calories if you consume them is a really great way to manage your hunger and get a healthier diet. And the thing that drives overeating is large portions. This is a wonderful study in which one of a nutrition scientist, he gave people medium or large popcorns going into a theater. They were fresh or stale. Stale meant he'd made it 2 weeks prior and left it on his lab bench. And what you can see from this crazy study is that even stale popcorn was consumed in greater amounts when the portion size was large. We all know that restaurants have obscenely large portion sizes these days. They have not yet got any better despite a lot of negative publicity. Think about strategies like when you go out to eat, before the meal even comes to the table, ask the server to pack away half of it so you can take it home. Strategies like that can reduce how many unnecessary calories of often unhealthy food that you eat just by reducing the amount on your plate. We also know that calorie density drives overeating. Muffins, brownies, ice cream, chips are all very low nutrient foods. They are not good for your health, and they're very easy to overeat. And then finally, there's variety, which is a much underappreciated source of overeating. High calorie variety causes overeating. If you have 3 kinds of cookies in your house, for example, it's likely that you will eat more cookies than if you have one kind. Variety causes unconscious eating. So it's also worth bearing in mind that if you, for example, focus on introducing more vegetable variety into your meals, you will probably end up eating more vegetables. So it's a principle of nutrition that you can use to benefit you in really quite easy ways. So hunger, the availability of food, calorie density, variety, and also familiarity are what we can call basic food drives. Those are things that we can use to help ourselves as we get older and we're trying to reduce the amount of unhealthy food we eat to make space for healthier things. In summary, most adults do today eat an unhealthy diet with inadequate amounts of healthy foods. That's to say lean proteins, fruits, vegetables, whole grains, legumes, dairy, and they eat too many unhealthy foods. We also know that obesity is harmful at all ages, and that we know that decreasing energy requirements means that there's less room for junk food in our diet, and to focus on high nutrient foods generally is crucial for weight maintenance and for health in old age. Rather than, thinking about just protein, think about getting rid of the junk food, because all of those healthy foods that you will eat instead, they have protein too, but they also have vitamins, minerals, polyphenols, all of the things that help prevent the diseases of aging. I strongly believe that weight and nutrition are interconnected, and that by reducing unhealthy foods, you also make weight management easier. So you get a kind of a twofer of benefits from both more nutrients and the avoidance of obesity and its health problems. Nutrition is probably one of the single most important things that we can do, along with exercise, of course, to help us age in a healthy way. Because most diseases of aging are actually unhealthy nutrition, either directly via the nutrients or via the obesity that they cause. So I think learning how to enjoy healthy food, focusing on the healthy foods that you do already love and increasing that number is a great way to stay healthy. Thank you very much.
Thank you so much, Roger, Susan, Jack. That was fantastic. And we already have a number of questions, which I'm going to field for you. And Susan, I'm going to start with you because I know you have a deadline. We're going to try to get to as many of these questions as we can. We may run over a little bit. So if folks want to stay with us, we invite you to. But Susan, I want to start with you. You mentioned, Roger and Jack mentioned protein, and you mentioned protein. I just wanted to have you clarify, because I know that getting enough lean protein in the diet is often talked about as really important for promoting muscle health. And you talked about the number of older adults who are actually not meeting the recommended amount. So can you just talk a little bit more about protein in that context? You're still muted.
Yeah, I'm happy to talk about protein more. And I know that Roger has strong feelings about protein too. I think the data is not yet great to think that older people require more protein. About half of older adults already report consuming plenty of protein. And on the other side, there are disadvantages like, affecting kidney function negatively from a high protein diet, that if you go overboard with protein, I think that could be problematic. So I think focusing on getting rid of the junk foods and adding really nutritious foods to what you've got is a great way to kind of focus on, to be mindful of protein sufficiency without going too far in the other direction.
So not overcompensating, but making sure we're meeting the recommended requirements. Dr. Fielding, Dr. Guralnik, do you have anything you want to add on that before we move on?
I definitely think we need to be more concerned about people who are not getting an adequate amount of protein in their diet.
Right.
There is some evidence that in combination with exercise, added protein may be beneficial. That may be a special case for people that are doing a lot of particularly resistance training, and the timing of when they consume that protein may also be important, that they're getting enough protein throughout the day in proportional amounts in the breakfast meal, lunch, and dinner. That is also important, but I think it's the inadequacy of protein that we need to primarily focus on.
Okay. And as Dr. Roberts pointed out, there are quite a number of folks who are getting an inadequate amount.
Absolutely.
Just to add to that, if we look specifically at the population with sarcopenia, the older population, they tend to have more chronic diseases and other issues that have led to their sarcopenia. So compared to the general population, they would be much more likely to be protein deficient. And if we evaluated their protein intake, it would be insufficient.
Great, thank you all. Dr. Roberts, I'm going to send a couple more your way in the interest of your time. One is that you mentioned supplements, and I know from the work that we've done for Aging in Motion that there are a lot of older adults, because of chronic conditions or because of medications, or as you said, because they require fewer calories, actually would benefit from supplements. They may not be getting everything that they need. So would you just talk a little bit more about your recommendations for supplements and who should be taking them?
Well, I think everybody who's thinking of consuming supplements should consult with their PCP to make sure that in their case that this is a good idea. My general recommendation is, I think something like a 1 a day all-purpose multivitamin is a good place to start. Those are customized for men and women, etc. But the advantage of them is that they usually don't have, excessive amounts of any one thing.
Another question, looking at muscle mass. Can muscle mass be improved once diminished? And if so, how?
Yeah, I mean, I think the best evidence for that is particularly in healthy older men and women, that supervised resistance exercise training has been able to show that not only will you increase muscle strength in response to that intervention, but there's described studies that have shown significant improvements in muscle mass and muscle size in response to resistance exercise. I think the capacity for muscle to increase its size and to grow does tend to go down a little bit as you get older, but it's not completely lost. So you don't get the robust hypertrophy in muscle with resistance training that a young person may have, but that capacity is still not completely lost as you begin to age.
Okay. And oh, go ahead, Dr. Guralnik.
No, I mean, I think that study that Dr. Fielding showed from Maria Fiataroni from the early 90s just amazed everybody, that she took older people in nursing homes and showed that an intervention like Dr. Fielding is describing can increase muscle strength in people that pretty much many people have given up on once they're in a nursing home. So it's like never too late. And that's proof that that's the case.
Yeah, I think that's a really important take home. And the flip side of that is something that you presented, Dr. Guralnik, on that extreme muscle loss from bed rest in older adults, which it was just stunning. Is that kind of muscle loss seen in someone younger who may spend the same amount of time with bed rest?
I haven't seen a study that did it exactly the same way, so it's hard to answer that. Maybe Roger knows that, but certainly younger people lose muscle too, but older people, and this was in healthy older people. If you have, you're hospitalized and you're sick, especially if you have an inflammatory type condition, you lose muscle even faster. But Roger, can you?
Yeah, the degree of bed rest that was seen in that study in older people was much greater than you would see in a younger person, which I think was really important. Even though they were healthy, the loss was greater than younger people exposed to a similar amount of bed rest or even longer periods of bed rest. Yes.
Okay. One person asks if taking metformin is a risk factor for muscle loss.
No, although there's some interesting studies that have been done, and I don't want to, we need to confirm them, that have shown that metformin may blunt some of the adaptations to exercise training in older adults. I'm not sure how to interpret those results right now, but I think it's something we have to think about, because there's a lot of interest in metformin as potentially being a therapy for delaying aging or promoting health span. But there are these interesting studies that may suggest it interferes a little bit with exercise training responses.
Okay, thank you. Dr. Guralnik, did you want to add something to that?
No.
Okay. We have a question that was acknowledged as being answered by Dr. Guralnik on are primary care doctors equipped to evaluate for sarcopenia, or should we be requesting they look at it? And I want to take a stab at just answering that by asking folks who are interested in that. I mean, obviously, Dr. Guralnik shared some of the data from the survey that we conducted that showed that there does need to be raised awareness, and you may need to be initiating the conversation with your PCP, but also direct people who want to read more about that survey to agingresearch.org/aging in motion. And you should be able to find those survey results, because I think it's really interesting. Next question we have is there any specific number or times for rising from a chair? So the chair test, how long should it take, and how many times do we need to do it?
Well, it's part of the short physical performance battery that Roger described. And people take around 12 seconds to stand up and sit down 5 times. Once you get out to much longer times, 18, 20 seconds, that's too slow. What's interesting that we found is that it's not an off or on thing. It's a continuous relationship, so that the risk of future adverse outcomes goes up stepwise as time gets slower, or it takes longer to do that test. So there's no clear single cut point like you might have in a lab test. It's a continuous relationship.
Okay, and I think that question also implies doing it at home, which you certainly could measure that, but it's also something that if you're concerned about you or a loved one, you should be talking to your clinician about. Here's a question about muscle loss. Is it usually symmetrical? This person says they've noticed muscle mass loss in one leg more than in another.
Well, we do have some asymmetries in muscle strength and size on the left or right side, depending on what limb is more dominant, what leg we would typically, if we were inclined to kick a ball, we would kick a ball with. And it's possible we may notice more decline on one side versus the other. But generally the loss should be symmetrical across both legs, unless unless you've encountered some sort of musculoskeletal injury or neurologic injury that's sort of directing sort of atrophy to one side. But you may notice it more simply because you may have more or less strength or mass on one side versus the other, just because of how you've used those limbs over your lifetime.
Okay, so a number of factors. Here's a question on exercise businesses that are advertising 2 20-minute sessions per week will build your muscle. Do you think that's enough? Is that a fair advertisement?
Well, I mean, I think the public health guidelines for older adults are pretty clear that two times per week is sort of the minimum amount to see gains in strength and improvements in function, or get some of the benefits of resistance training. So I think that's enough. And I certainly think that many people that want to begin or engage in something like resistance training, they may not be very familiar with what they need to do and how to do it. So very, very generally, we do recommend, if people have the resources to do that they could engage in a appropriately trained or certified personal trainer, or seek out some community organizations where exercise programming is available. We always recommend people go to their local YMCA. Those are usually very, very well vetted programs and fairly reasonable if you can get to the Y. There is strength training equipment usually at most Ys, and there's some sort of programming available to sort of learn how to do resistance training. So those kind of programs, I think, are appropriate. And if people are interested in becoming engaged in doing more strengthening exercises, that's a great way to start, because people may not always be familiar with how to use the weights. And we certainly don't want to recommend someone do something where they're going to put themselves in a situation where they get injured. So
that's a great point.
And the key here really is consistency. You start 2 times a week, you need to keep doing it 2 times a week. Right. So
Yeah, great point. And build up from there if you can. Jack, this is something that I've heard you talk about a lot. I mean, you both have, but in our work with aging in motion, the question is, can you talk a bit more about therapeutics for sarcopenia that are in development? And then also whether we have a consensus definition of sarcopenia in the eyes of the FDA.
Well, I think Roger covered pretty well the categories of intervention. There have been a few drugs that have undergone major clinical trials. And one of them, in fact, showed that it did increase muscle mass, but it did not increase strength or functioning. And the FDA has been pretty clear that a drug will not be approved simply because it creates more muscle. It has to have a functional impact, reducing the loss of mobility, for instance, reducing falls, something that's kind of the final product or effect of having muscle loss. So the FDA is recognizes, I believe, that loss of muscle is an important issue in older people. They, like the rest of us, don't have a strict, clear definition of sarcopenia that should be used universally. I think that we're still a ways away from that, even though there have been a number of, international consensus conferences that have come up with definitions. Nothing is perfect right now. So we're still a ways away from that. And I think that once we have a good definition, the FDA would accept that definition.
Okay, here's a question from someone who is taking a medication for diabetes and has experienced weight loss and muscle loss and is having trouble getting their doctor interested in the concerns about muscle loss. So what specialist can they see to deal with muscle loss?
So I think there is a renewed interest. I mean, there are a lot of new weight loss drugs that have been approved recently to treat type 2 diabetes and obesity. These are the sort of the class of compounds called the GLP-1 agonists. And the way they primarily work is to reduce the person's food intake, essentially. And they have been very successful in causing weight loss, but a component of that weight loss is very clearly been loss of lean mass or loss of muscle. I think it's largely been flying under the radar, but I think as these drugs gain more widespread use, there may be some populations like older adults in which this loss of muscle that occurs may have some significant negative consequences. I think it's very early to know very much about that. I think it's very likely that if you are on a GLP-1 agonist and you're concerned about losing muscle, we know from dietary weight loss interventions that by adding some exercise and adding particularly some resistance exercise to the weight loss program, you can prevent the loss in muscle. Whether that's been proven with GLP-1 agonists or not, I don't know yet. It still may be early days, but I think it's very likely that if you could add some physical activity, some resistance exercise, you could help to prevent some of that lean mass or muscle loss that occurs with the weight loss and when you're on a GLP-1 agonist. But much more to learn about that, and it's just kind of emerging as kind of a hot topic right now. I've been talking a lot about that recently, so very interesting question.
And as people change their diet, as their appetite is reduced, they need to pay attention to getting enough protein, because as you eat less, you tend to eat less of everything, and that may not be the best way to do this.
There's a question here that's related to protein intake and wondering if it's important to stay aware of hydration levels as you increase your protein consumption to help combat things like kidney stones.
I mean, I think it's important to be aware of your hydration status as you get older.
No matter what, right?
Many people lose a little bit of their thirst mechanisms as they age. So if you're engaged in physical activity, you're out in warm environments and you're losing a lot of body water from sweating, and being physically active, you should be more aware and be aware of proper hydration. Whether high protein causes kidney stones or not, I think that's a very, very open question. But I think in general, people need to be a little bit more aware of their fluid intake and their hydration status and make sure that they are getting enough fluids every day.
And this question's related to protein, and I'm just going to direct folks. This says, how much protein should an older adult be getting? And I think it's important that people can look at the USDA's recommendations for different age groups, because they are differentiated and giving general recommendations. But is there anything that you want to add to that on how much protein older adults should be getting?
The quality of protein intake matters. So remember that, high quality proteins are those proteins that are dairy, lean meats, fishes are higher quality because they have the same amino acid composition as we have in our own bodies. So those are higher quality proteins. It doesn't mean that the protein from plants and plant sources is bad. We just have to make sure that we combine them in appropriate ways to get an adequate amount of the essential amino acids, the building blocks of proteins from those foods. So we have to be a little bit more careful, but protein quality is also important. And
do we need to spread protein intake throughout the day? Or can I have it all for breakfast?
There are some interesting studies that, particularly in older adults, that they consume much of their protein exclusively at the evening meal. And if you believe that, and I do believe this, that protein synthesis and the capacity to synthesize and break down proteins happens throughout the day, you're missing lots of windows of opportunity to sort of maximize protein synthesis and net protein sort of accretion if you're only consuming most of your protein at dinner time. So the evidence suggests that getting some protein at all 3 meals during the day is probably better than consuming it just or mostly at dinner time. And I think that makes good sense.
Okay. Dr. Guralnik, this is a question that I think touches on a piece of your presentation on the impacts of sarcopenia. How does it affect either directly or indirectly vascular health and brain function?
Well, in terms of brain function, sarcopenia has a direct effect on how physically active people are. And we know that maintaining a good level of physical activity is a good way to maintain brain health. So in that way, while there may not be a direct effect of the muscle on the brain, the fact that reduced muscle leads to reduced physical activity does have, kind of wide-ranging negative effects on overall health, and particularly brain health. So I would see the connection as working in that way.
Okay, great. I know we're running short on time and folks are going to start to drop off. So I do want to answer the question of, can we get a copy of the presentations, and also added a wonderful information. So absolutely, we will be reaching out with a recording of this webinar and the Q&A section and sharing it with everyone who registered and attended. So absolutely. We also have a question about someone asking about being involved in research. And so I wanted to direct anyone who's interested in that to clinicaltrials.gov, where you can see if there might be a research trial going on that you or a loved one can help contribute to. Couple more questions before we have to go. There's a lot of questions about different medications and their impact on muscle loss. One is statins, and the other one, I'm going to butcher the pronunciation, anastrozole. So are there any medications, maybe we should go there, that we know, or statins again, that we know cause muscle loss?
I'm, the research just isn't there. We
Okay.
have a certain, research on sarcopenia is growing, but this relationship to drugs, I'm not aware of any good studies. I don't know whether Roger is.
So I think, the most obvious one that's probably most commonly used in some treatments is, some of the corticosteroids can cause muscle atrophy. But if you're only using those, for intermittently, it's not going to have a big effect on muscle, but if someone was on a corticosteroid for a longer period of time, it could cause a little bit more muscle mass. The question about statins in muscle does come up. Some of the statins seem to cause a very sort of unique type of muscle injury that basically goes away if you just put someone on a different statin medication. But that also may be very personalized in that not everybody has that response to these statins. So there are some examples of this. But I think Jack is correct that, we don't know quite a lot about medications, but it's important to remember that many older adults, not all older adults, but many older adults are on multiple medications. So this may be important in trying to unravel sort of sarcopenia and who's at risk and how we intervene and treat sarcopenia ultimately. So those are good questions.
Well, the flip side, I'm seeing a number of questions that have to do with benefits. So someone asked about blood pressure restriction cuffs in training, muscle vibration, other medications that might improve testosterone, that might improve muscle gain. Is there anything there that, obviously, Roger, you spoke about resistance training, but any of those things that
Yeah. So there is
Yes.
some interesting evidence with the blood pressure cuff restriction and sort of optimizing gains to sort of exercise interventions. I'm someone that likes to be physically active, and I can't imagine myself trying to do my exercise routine with a blood pressure cuff restricting blood flow. And I just don't think it's that practical, but there is some evidence to suggest there's a positive effect, so it might work, but I don't know if it's going to be something we can adopt easily. I think there's some evidence that the vibration platforms may improve balance, although I'm not an expert on sort of balance training. That's possible. And the data on testosterone has been mixed, I think. It depends, the doses that have been using sort of testosterone patches or androgel. The large trial in older men that had low testosterone levels at baseline showed that it didn't improve 6-minute walk distance, although there may have been a subgroup of individuals that improved. However, there are older studies looking at injectable testosterone therapy, but by injection, higher doses generally, that have shown that it does improve muscle mass and muscle strength. Although I think you have to think about these very potent steroidal SARMs like testosterone. They do have a number of side effects that I think we need to really carefully consider in older adults. And that's why I think there's been some interest in developing other more specific SARM or selective androgen receptor medicines that target androgen receptors like testosterone, but with less of a better safety profile. So there may be treatments, but I don't think we really have things that we can say are approved or approvable yet.
Okay. One very specific question. I'm really curious. Does muscle mass loss in aging adults occur most often in joint extenders versus the joint flexors?
I think it's pretty symmetrical.
Okay.
Now you have to remember that the joint flexors tend to be a little bit weaker than the extenders, at least in the knee, for example. So you may see the declines in strength and mass more dramatically earlier in the flexors than the extensors, at least in the lower extremity.
Okay. And then I think we've covered all the questions in some way, shape, or form, but I do want to throw this one out because I think this is a question people often have when we're talking about weight. So who develops the BMI and does it consider body type?
I'll let Jack, as the card-carrying epidemiologist, answer
You mean
that.
who develops the BMI?
Well, I guess it was, where did the BMI come from? I think the more, to me, I think, does it consider body type is the piece of that question that's really, really interesting.
Well, the BMI, of course, uses both weight and height. If you just look at weight, you don't know whether it's a tall person or a small person, but you've got to add height in. And so it's a relative measure of of weight for height. That's proven very valuable, although somewhat controversial, because weight can be fat weight, it can be muscle weight. So there are, highly conditioned athletes who have higher BMIs because they have so much muscle. But BMI itself does not consider body type, although it gives some indication of body type. If you've got a very high BMI, you are obese, and so that body type, but it doesn't really go into any more detail than that in terms of specific body types.
Okay. Well, I think we have definitely run over on time, but I appreciate everyone who was able to stay on and contribute their questions. And Dr. Guralnik and Dr. Fielding, thank you for staying and fielding all of these questions. And to Dr. Roberts, who had to jump off, thank you for contributing. All of you, this is chock full of great information, which we'll be sharing with everyone. Again, we'll share the recording with everyone who registered. Please pass it on to anyone who might be interested. And then come visit us at agingresearch.org/aginginmotion. You'll find this webinar. You'll also find we developed an educational film that really tries to boil down some of the key points of sarcopenia, make it accessible. So if you're interested in that or want to share it or educate your audiences with it, please do come and find it or reach out to us. But thank you to everyone and to Nestle Health Science for helping support this webinar. And I really appreciate your expertise, gentlemen. Till next time, thank you so much.
Thank you, Lindsay.
Thank you.
All right,
Lindsay.
bye, everyone.
Bye-bye.